Now, there is some good news that has occurred on the delivery system reform side and on the coverage side also since the passage of the Affordable Care Act. We have 360 Medicare accountable care organizations serving close to 6 million people. It's not a big proportion of the Medicare eligibles, but it's beginning to be a substantial fraction. $372 million in savings generated by Medicare ACOs and Pioneer ACOs. A lower rate of increase in Medicare costs in Pioneer ACOs, and actually accountable care organizations have consistently exceeded their quality goals as specified under the Affordable Care Act. So we have lower costs and higher quality. That's not a bad portrait for a relatively recent healthcare reform. They're much more diverse in their location than one might have expected. It's hard to find a spot in an area in the United States that doesn't have some ACO activity. Again, a little more dense in the north and the northwest, but still you can see it in Texas and in Florida and in some parts of the south. We have now reports on the prevalence of hospital-acquired conditions, which we never had before, that are available through the Medicare organization. I'll say a little bit more about what's happening to hospital-acquired infections in a moment. The Center for Medicare and Medicaid Innovation, which I believe will be a very central target of a minority-majority Congress, has done a lot of work in a lot of places engaging providers in innovation. This is innovation which will not spread if we don't have macro system reform, but has the potential to spread if the incentives are properly aligned. We have some good news in where it counts, at the bedside. We have an historic rate of reduction in healthcare-associated infections, documented from 2008 to the current time by CDC with good, consistent data reported by most of the United States hospitals. 44% reduction in central line-associated bloodstream infections, 20% reduction in surgical site infections in colon surgery, 11% in abdominal hysterectomy. These are fewer people dying, shorter lengths of stay, less money spent, happier patients. This is a big step forward. The Accountable Care Organization doesn't explain this. The Affordable Care Act doesn't explain this, but the Affordable Care Act perpetuates the incentives that initiated these changes, which largely came from the Medicare program. And then hospital readmissions nationally are declining. It's hard to explain this through anything other than the Affordable Care Act, just temporarily. The average has gone from about 19% to about 17.5%. Only 1.5% doesn't seem like much. That's 150,000 admissions that are not occurring a year. 150,000 is the size of Salinas, California, Kansas City, Kansas. Imagine a whole city not trooping to the hospital in a given year because of changes that have been accomplished by clinicians with incentives from macro system reform in the form of Medicare payment changes. Now, we published a piece in the New England Journal that quantified the numbers of Americans who since 2009 have been touched through by the coverage provisions available under the Affordable Care Act. The number comes to about 21 million. This is probably a slight underestimate by now. But one hears mostly about the marketplaces when you talk about coverage expansions. The marketplaces are actually a relatively small portion of Americans who are affected by the coverage provisions of the Affordable Care Act. There are now probably more than 8 million new Medicaid and CHIP enrollees, between 1 and 3 million young adults who are newly insured through the coverage under their parents' plans. That's something you will not see any Republican-controlled Congress trying to repeal, regardless of what else they do. So 21 million touched. Now, there was a big kerfuffle about whether, in fact, we were having as many cancellations of plans as we had new plans issued. These are data from one of our surveys on the rates of uninsurance, look at the far left, you'll see that 20% of Americans in working ages were uninsured in July to September of 2013 when we did a pre-open enrollment poll. That number had fallen to 15% by the end of the first open enrollment period. The biggest reductions in uninsurance occurred in among low-income Americans. By the way, there's also an absolutely astounding reduction in the proportion of Latinos who are uninsured in the United States. Now, on top of this, we have this reduction in national spending, or rates of increase in national spending, from historic rates between 5% and 6% before the period of reform to rates between 2% and 3% right now. Can't attribute this to the Affordable Care Act in entirety, but we haven't seen and there's a raging debate among economists. Raging, it probably overestimates how fiery it is, but there's a intellectual debate that tries to be fact-based on what's causing this reduction in the rate of increase in healthcare costs and whether it's going to continue. But it certainly isn't the case that the predicted increases in costs have occurred. So, does all this mean that we are at the dawn of a new day? We've got reduced uninsurance, we've got improving surgical and other sources of infection. By the way, diabetes care is a recent triumph. The rates of complications from having diabetes are dramatically lower. The New England Journal published this CDC data about 6 months ago. Much less likely if you have diabetes now to have a stroke or a heart attack than you were 10 years ago. So something's working in terms of diabetes care. Moderated costs, clearly things are better, right? Well, it's a little soon to start applauding because the Medicare actuaries are still predicting that there will be a resurgence in healthcare costs, and pharmaceutical specialty spending will probably be a leading cause of that resurgence. We still don't understand why costs are moderating, so we really can't have a lot of confidence that the effects will continue to have at this historically low rate. Now, one thing also to understand is this slide here. So if you look at this, starting on the upper left, you'll see GDP, national GDP in the major countries on the globe, and you'll see that the US, this is 2011 data, the US led the world with a $15 trillion GDP. China followed next, Japan was next, Germany was next. And what's that thing on the upper right-hand side there with a stethoscope over it? Well, that's the US healthcare system. If the US healthcare system were a country and you put it on an island and floated it out into the Atlantic, it would have the 5th largest GDP in the world. That's where we stand. We in this room are part of a country that has the 5th largest GDP, or economy that has the 5th largest GDP in the world. If we want to reform the healthcare system, we have a task as substantial as France or Germany trying to reform their entire economies, both in terms of numbers of people employed and in terms of dollars coursing through that system. Now, another way of thinking about the challenge we face, and this is sort of the challenge of sunk costs. Economists talk about opportunity costs, and we know that when we pay for healthcare, we could be using that money in another way. So I had one of my colleagues at the Commonwealth Fund put this slide together. What it looks at in the upper part of the slide is the difference between what we actually have been spending in the last 30 years on healthcare and what we would have spent if our healthcare costs had gone up at the same rate as the Swiss. Now, Switzerland in 2000 and in 1980 had the 2nd highest rate of per capita healthcare spending. If we had gone up in healthcare spending at the same rate as the Swiss, we would have saved $15.5 trillion over the last 30 years. What could you do with $15.5 trillion? You could retire our entire national debt and turn it into a $3.6 trillion surplus. You could have sent 175 million young Americans to college free of charge. You could have increased spending on public health by 20,000%. Think of Ebola now, and how we've hollowed out our public health infrastructure over the last 10 to 20 years. And we could have bought everyone in the world 4 iPads. Now, we still have an agenda of reform in the United States. Whatever we believe, whatever progress we have made, it is the challenge is not over. The need to create a high-performing health system, to invest in it, and to continue to innovate, to do so is still critical. What about the state of Massachusetts? In the area of healthcare costs, we know that we spend more per capita on healthcare than any place else in the United States. This slide kind of captures how much more we spend relative to the United States on various types of care. Hospital care, $1,000 more, long-term care, $770 more, professional services, $580 more. This is a very important slide. This slide looks at the far right, your far left. You'll see how much healthcare spending went up between in this century on the state budget. It increased from about $9 billion to about just short of $15 billion, about $5.4 billion, 37% increase in the last 14 years. What happened to mental health spending? It declined 22%, public health spending 31%, education 12.2%, human services 11%, infrastructure, housing, and economic development 14%, law and public safety 13%, local aid to cities 50%. Now, I don't know that there was a one-to-one correlation between the increases in health care and the reductions in other investments. But I do think this dramatically illustrates the societal trade-offs that we face and why we can't rest on our laurels with what we've accomplished up to this point. The education of our young people, the future of our roads and bridges and the industries that they support, the ability to take care of crime and fight crime, all these things that create a civil society are at risk. And healthcare is clearly one of the reasons why they're at risk. We have a very interesting healthcare system. We're not immune to the trends that are going on throughout the United States. Healthcare is consolidating throughout the United States, and it's consolidating here in Massachusetts as well. This slide from the Health Policy Commission looks at the top 2 health systems in every community's proportion of hospital discharges. And you can see that there are a lot of places in Massachusetts where there is considerable dominance by a couple of healthcare systems in those localities. We also, and I have most of my career been a beneficiary of this, have a very large percentage of our discharges from teaching hospitals. 40% compared to the average of 12%. So these are just peculiarities of the, not peculiarities, but attributes of our local healthcare system that create challenges for us as we try to create a higher performing health system. Now, there's some really good news about Massachusetts that we can take real pride in. According to our state studies, our national scorecards, Massachusetts is the best or second best on quality, access, and equity, and and our measure of healthy lives, that is the proportion of lives lost to preventable illness in the United States. We have a high quality health system. We pay a lot, but we get something back for it. We have the lowest 30-day mortality rate for Medicare inpatients hospitalized for pneumonia, heart failure, or heart attack. As I said, we have mortality amenable to health care for blacks is near the US average for whites, which is a very, very remarkable achievement. We have the fewest at-risk adults without a routine doctor visit in the past year, and we have the second lowest rate of adult obesity. A lot we have to be proud of in this particular state. And we are seeing macro system reforms that I think will create the opportunity for innovation. I know I saw that before I left to go to the Commonwealth Fund at Partners Health System, and I am sure it is going on elsewhere in the state. We have a statewide target for increases in healthcare spending. We're the only state in the union that has that. You may not like that idea, but it does create a change in the macro system's pressure on local organizations to innovate. We have public oversight. We have a very dynamic private insurance market that is pressing providers to produce higher quality, lower cost services. We have the historic commitment of this state to universal access, which is one explanatory variable, I believe, in the higher quality of care that we're able to provide. We have 5 pioneer ACOs in a tiny part of the nation's real estate, and that's also an indicator and a cause of macro system change. I think these have implications for the state that are by and large positive. They're going to cause innovation in health system design. They're going to cause greater focus on the highest cost, most frail patients whose costs need to be controlled and quality needs to be improved if we're going to contain healthcare costs and improve value overall. We have high rates of adoption of electronic health records. Whatever you feel about electronic health records, clearly it is a marker of the effort to make things better. We have changing payment processes in our accountable care organizations, both under the quality contracts that are in place through Blue Cross and through the ACOs present. And I think, as I mentioned, that we are going to be seeing more and more targeting of the patients who most need help from microsystem reform. So I see reasons for challenge in the Massachusetts environment, but also real reasons for hope. I think our leadership, our capability to lead in the design and redesign of health systems is now supported by the kinds of frameworks that will make it profitable and useful and valuable to make those innovations. And I also think we come at it from a level of equity, which, if you believe in equity, is unparalleled in the rest of the United States.